thank you all for coming tonight. My name is Sara Gelser, and I'm the state representative from here in House District 16, which includes Corvallis and Lowith. Can everybody hear me in the back? Is the amplification okay? Great. So thank you for coming out tonight for an opportunity to have a conversation about where healthcare is going in the state of Oregon. I'm really grateful that all of the members of our panel were willing to come tonight, and that all of you were willing to come. Just as out of curiosity, for how many of you is this the first time you have ever been to a forum about healthcare in Benton County? First time. Very good. That's fantastic. So without a whole lot of delay, I'd like to just move into introducing our panelists. And the format that we're going to use this evening, there's a lot of people here, and I want to make sure that we get to the most diverse kinds of questions that we can. So we're going to do questions kind of League of Women Voters style on index cards. And Chris Scarro from my office is in the back in the white jacket, and she has index cards. No limit on the number of cards that you put in. We have some pins as well. Just raise your hands if you need them. And we're going to start off with some introductory comments from each of our panelists, and then we'll move on to those questions. But we have with us today Dr. Bruce Goldberg, who is the director of the Oregon Health Authority. We have Lisa Morawski from...
She's right here.
Cheer, right there. Moving her car. And this is new information that I learned tonight. We've talked a lot about the health insurance exchange. I'm very proud that Oregon was the first to create a health insurance exchange. I think that is something that we as Oregonians can be very proud of, and something that came out of a very bipartisan effort in the 2011 and 2012 legislative sessions. But we are now calling the health insurance exchange Cover Oregon. Is that correct? So our exchange is Cover Oregon. We have Kelley Kaiser, who is the CEO of Intercommunity Health Network. Also something that our local community can be very proud of as we move into healthcare transformation, being one of the first communities in the state to have a CCO up and running. We're now a couple of months into this, and that's one of the reasons we scheduled this for November instead of September, so that we probably will have more questions and experience in that process. We have Kim Whitley, who is the Chief Operating Officer of Intercommunity Health Network. We have Charlie Fautin, Charlie, from the Benton County Health Department, and Mitch Anderson from the Benton County Health Department. So thank you all for coming tonight. I'm going to pass it off to Bruce to kick it off.
Thanks, Representative Gelser, and thanks everybody. A lot of familiar faces in the audience, so I'm going to be brief because many of you could probably give the little talk that I'm going to give. We've all been talking about healthcare for quite some time in this state, really dating back about 20 years ago from the beginning of the Oregon Health Plan. And this past legislative session was pretty historic, thanks to Representative Gelser and her colleagues. We came out of the legislative session with two bills that really changed the face of healthcare in a variety of ways. And they're two bills that passed with hugely bipartisan support, something like 55-5 for both bills in the House, and 25-27 to 345 in the Senate. Which I think really demonstrated the degree to which this is a hugely important issue for Oregonians. And the fact that we can, when we really focus on the policy on health, we can get things done. You know, one of the biggest issues in our country today, certainly hugely in many places partisan and divisive, is healthcare. We have a couple of problems with our healthcare system, both in our state and our nation. One is that, sadly, we have too many people in our state and in our nation who go without basic healthcare. Here in Oregon, about 17% of adults have no healthcare coverage. And the other big issue is that healthcare has become incredibly expensive, and it's become unaffordable for too many of us. It's unaffordable for businesses. It's become unaffordable for the state to cover the most vulnerable, and it's unaffordable for individuals to be able to purchase health care. And so this past legislative session, we really tackled two of those big issues. One was the coverage issue, and that really dovetails with federal health reform. And Lisa will talk a little bit about the health insurance exchange in a moment, which is a way to provide affordable health care coverage for those who are working and are not living in poverty. And at the same time, we'll be able to expand Medicaid coverage under the federal health reform for everybody in the state living below 133% poverty. So January 1, 2014, we anticipate that about 95–96% of people in our state will be able to have basic health care. The big issue, though, is if we're going to put more and more people into a system that we can't afford, we've got to do something about the cost. And that's where our new coordinated care organizations come in. As I indicated, healthcare has become really expensive. If we were really getting great value from that, if we were the healthiest state, the healthiest nation in the world, that would be a great investment. But I think, sadly, as many of us know, we've got great advances in our healthcare system. We've, here in Oregon, invented a simple pill to be able to cure cancer, which is fantastic. But yet, we've got a really complex system to be able to get that pill, and not everybody can get it. And so we've got to really focus on how we create a simpler system, how we are able to get some of the waste out of our system, create a more sustainable, cost-effective system. Our plan to do that is to create local coordinated care organizations. You'll hear about one of them tonight from Kim and Kelley. They are 105 days old today. They've been at this. We now have 15 coordinated care organizations in the state. And what these are, it's a new way to deliver health care for those on the Oregon Health Plan. And it really does a couple of things. One, it brings together all the pieces of the healthcare system. Doctors, hospitals, strong consumer involvement, all the providers in a community, to really work together under a single umbrella to improve the health of the community. This is really about local control. It's about providing local communities with a budget to this CCO that grows at a sustainable rate, 3.5% a year, something that we can all afford. Hopefully that's going to be consistent with how most of the major economic indicators grow in our state and our nation over the next decade. And at the same time, not just hold these organizations accountable for living within that budget, but also for some clear accountable metrics for how to improve health. So not just holding organizations accountable for dollars, but for improving the health of the population that they serve. We believe in our local community healthcare systems and think that this can be something that works. We've begun this in the Medicaid system. If this is something that can work, we hope to look at expanding this model to others and see how that works. So I'm going to stop there, let Lisa talk a little bit about the health insurance exchange, and then Kelley and Kim can tell you even more about local coordinated care organizations.
Thank you. So the health insurance exchanges are an important piece of federal health reform. And as Bruce mentioned, it's really about making health coverage more accessible to folks. And in Oregon, our health insurance exchange is called Cover Oregon. We actually just announced our new name last month in October. Basically what the Affordable Care Act and federal health reform do is they give the states the option of developing their own exchange, or they can use a federal health insurance exchange. And so in Oregon, we've actually been talking for many, many years about the idea of an exchange. And so the legislature and governor thought it was very important to develop our own exchange here in Oregon. And it had been in the works for many years, but what the federal law does is actually give us the funding to get it started. And so we're totally federally funded in the startup phase, and then once we're operating, we'll be self-sustaining. So there's no state money that goes into the exchange. So basically, I wanted to talk a little bit about what an exchange is, because we found as we're starting to get out and talk to folks, the term is still really foreign to people. And actually, that's one of the reasons that we're trying to get away from the term. You'll hear it a lot nationally, but in Oregon, we did adopt the name Cover Oregon, because when talking to individuals and small businesses, exchanges didn't really resonate with people. They weren't really sure what it meant. But the idea behind an exchange is to have a central place where people can shop for health insurance, and it's very transparent about the plans and really makes it easier for them to sort through their options for plans. And a good way to think about it is to think about like Travelocity or Orbitz and some of those sites where you book your travel. We're not a health insurance company ourselves, but we are a place where health insurers can offer plans through us, and we're kind of like a clearinghouse in that sense. But we are different from some of those private websites in that we are a public corporation. We were formed by the Oregon legislature, and so we're accountable to the public. We're run by a board of directors. And actually, I noticed our vice chair of our board is in our audience today, Terry Andrews, who's from Corvallis. And our board is really consumer focused. We have small business owners. We have Dr. GOLDBERG is on our board. We have health professionals, and we have consumers on that board. And so they really direct the work of our corporation. And kind of another thing that's different when you try to think of, if you try to compare an exchange to a Travelocity or whatnot, we're working really hard to make sure we have high quality choices for consumers. And so all the plans and the companies that offer plans through Cover Oregon have to meet our requirements. They need to do a lot of reporting to us on measures they are taking to improve quality and to reduce costs in the healthcare system. And we're hoping in that way we can really help contribute to Oregon's overall efforts to reduce costs in the system. We're also going to be grading the plans based on a lot of the data that we collect, so that consumers, we're going to have a star rating so that consumers can look at plans and really compare them for different criteria. Another thing that is really going to make coverage more accessible is there will be financial assistance available through Cover Oregon. The Federal Affordable Care Act provides tax credits and some other subsidies that can help people pay for premiums and pay for deductibles. And we think that's really going to make coverage a lot more accessible to folks. We actually, if you go to our website at coveroregon.com, we have a calculator on our website where you can punch in your income and number of people in your household. You can get an idea of what you might qualify for in 2014. We think it's really going to help a lot of folks. So kind of the time frame, we are working on developing Cover Oregon. Right now, we've been at it for about 1.5 years since the legislature formed the corporation, which was in June 2011. And we will be open for open enrollment starting next October 1st, 2013. And then coverage for plans purchased through Cover Oregon will take effect January 1st, 2014. And that's when a lot of the other provisions of the Affordable Care Act take effect, such as no more pre-existing conditions, and all the tax credits and financial assistance that's available. And so we're working really hard right now. We have, we're growing really fast. We have about 40 employees right now. We're working on all different areas to get Cover Oregon up and running. It's a huge task. And we've been working a lot over the past year on kind of the back-end technology system of how this is all going to work. Because we're going to have individual plans available, small group plans available. You're going to be able to access the Oregon Health Plan and Healthy Kids all through one website. So we've been working really hard on the IT side, and then, but more recently, we've been focused on actually the design of the website and what it's going to look like and how you're going to be able to search for plans and what criteria you're going to be able to put in. And so we've started some usability testing with individuals and consumers, and we're going to be continuing that over the next few months. I wanted to throw out there, if anybody's interested in testing out our website, we're looking for folks right now. So contact me after the presentation, or if you want to shoot me an email. I sent around some fact sheets that have some contact information where you can get a hold of us. And I encourage you to visit our website and sign up for our email updates if you want more information and want to keep apprised of what we're working on at Cover Oregon. All of our board meetings are open to the public, and we take public comment at any time. Periodically, we'll put questions out for people to get public input. We actually just this fall, we're putting together the requirements for the health plans that are going to be available through Cover Oregon, so we put those out on our website for people to comment on, so you can look for those types of things. So if you're interested in kind of staying abreast of what's going on, I encourage you to visit our website. And that's kind of a general overview, so I'm happy to answer any questions.
All right. So I'm going to talk a little bit about the coming together and responding to what Dr. Goldberg talked about in terms of the coordinated care organizations. And I'm going to focus a little bit on the governance part and how we've come together. And then Kim was going to focus on our transformation goals, and Mitch was going to focus on our community advisory council. So we're tag teaming our approach here in the Mid-Valley, because that's really actually what Charlie's going to talk about, how he's going to bring it all together with public health. That's kind of how we work here in the Valley, and so that works well for us. We started meeting in the beginning of 2011 to talk about the legislation that was coming and how we, in our service area, would respond to that legislation. We had our first meetings in February of 2011. Those meetings included county commissioners, county staff, public health staff, Samaritan physicians, independent physicians, mental health providers, the Cascades West Council of Governments, A&D providers. We had a really broad group of people that had come together to talk about how we would respond to this legislation and how we would come together and work together and move forward. And so that has been a great group that has been coming together for almost 2 years. That group still comes together monthly. We call that our regional planning committee. And they still come together and are really working on the transformation piece and driving that change. So you'll hear more about that in a minute. From a governance perspective, I wanted to talk a little bit about the Intercommunity Health Network, CCO. We were formed in 2012 in terms of reshaping and relooking at Intercommunity Health Network, which had been an existing managed care plan that administered the Oregon Health Plan and had been doing that since 1994. We redid all the bylaws and the articles, broadened the board, and really changed our approach. And so I think that I wanted to just quickly say what our mission is, because I think it really talks to our collaborative nature that we have. So it's by local, private, nonprofit partners and public partners to unify health services and systems for Oregon Health Plan or Medicaid members in Benton, Lincoln, and Linn counties. We are committed to improving the health of our communities while lowering or containing the cost of care. We'll accomplish this by coordinating health initiatives, seeking efficiencies through blending of services and infrastructure, and engaging all stakeholders to increase the quality, reliability, and availability of our care. So that's really, as a governance group, what the focus is and what they get together and really strive to achieve. Our governance board consists of about 17 people right now. The chair of our Community Advisory Council will be appointed to that board in the next month or two. And we have one more member getting ready to join the board as well. So it's a really broad group. We have 2 county commissioners, 1 county administrator. We have a hospital administrator. We have 1 mental health doctor, 2 independent physicians on the board, 6 community members, so 6 members from the community that are not related to any of the entities. And of course, we'll have the chairman of our Community Advisory Council. So it's been a great group that's only been meeting for about 6 months now in terms of coming together, but many of those people have been around that stakeholder table for almost 2 years. So I think that we've really come together, and I'm pretty proud of what we've accomplished so far, even though it's only been 105 days, we have a lot of work to do. But continuing to meet and to collaborate and to innovate between all of the various committees has been very successful.
Thank you, Kelley. So as Kelley mentioned, my name is Kim Whitley, and I'm the Chief Operating Officer involved with Intercommunity Health Network. And I've been involved in both the proposal to become a CCO and the implementation that we've gone through in the last 105 days. And really my task has been helping our organization meet the contract requirements that's a part of our agreement with the state to be a CCO. And I really wanted to focus today on a piece of that contract that's called the transformation plan. In our contract with the state, we're required to have a transformation plan. And this transformation plan really speaks to our position as a community on how we're going to improve access, improve quality, while decreasing the cost of care. And the transformation plan has several elements in it. It talks about we have to explain and talk about how we're going to support the primary care home model. We have to talk about how we're going to change the payment model, how we're going to involve non-traditional health workers in the care of our people and improve their care. We have to talk about how we're going to integrate mental health and physical health, improve care coordination for members, address quality issues, disparities in care, and improve health literacy. So all of those pieces go into this transformation plan. When we looked at this as a community, that's a pretty daunting task. It was actually, it's due to the state in January, and they're going to be reviewing it at that time. And we thought it was really important to get an early start on it because this is a big thing. We cover 3 counties, and we wanted to make sure that we were involving all the stakeholders and got information from everybody that would have input to do that. And our approach was to start with the people who provided care. We thought, oh, sure, thank you. We felt it was really important if we were going to change the culture of care, as we've been tasked to do, that we would need to start with the people who actually provide that care. So we asked people, care providers from across the 3-county area to come together and start meeting and talking about how they can transform care. And so we did that. We put together what we're calling a Delivery Systems Transformation Committee. It's made up of clinical providers, mental health providers, and physical health providers. Long-term care is involved, in addition to our mental health authorities and some addiction counselors. And these folks have come together and looked at the requirements as proposed by the state, and they've decided to approach transformation through pilots in each of our counties. They really felt, because we do have all the county health departments are involved, because there are similarities within each of the counties, which is a very exciting prospect to expand upon, but there are also significant differences in how care is delivered and the needs of each county. And the transformation team, the Delivery Systems Transformation Team, really felt it was important that those differences be recognized and addressed. And so they decided to put together a process of having a pilot in every county that would look at transformation with the needs specific to that county. So in Lynn County, we are looking into a pilot related to readmissions. And so we have a group of folks involving the health department, long-term care, and the mental health authority and addictions involved in that pilot, in addition to Samaritan Health Services and the Corvallis Clinic. In Benton County, we're looking at how to improve the coordination of care in the primary care home. And that's involving Samaritan, the Community Health Department, and the Corvallis Clinic, and some independent physicians. On the coast in Lincoln County, we're looking at mental health integration and how to improve access to mental health. And then we have one additional pilot that's geared toward health disparities and health literacy related to mental health awareness and integration into physical health, recognizing that IHN has not managed mental health in the past and has the need to really focus on that and ensure that we're meeting all the needs in that arena. So that is really what we're doing from a transformation perspective, and of course I can answer additional questions on that. I did want to mention that the state, in their support of this requirement of the contract, is developing a transformation center and innovation center, and will be assigning us as a plan and innovation agent. And we, on our side, have hired a transformation manager, and hopefully those two will be connecting and really starting to put some speed and some power behind what's happening for us as our 3-county-wide CCO. So anyway, there's more, I'm sure there'll be a lot more coming on that.
Thanks. My name is Charlie Fautin. I'm Deputy Director of Benton County Health Department. I'm in charge of public health programming. And Representative Gelser asked me to speak briefly to the part that public health plays in the CCO plans. And start with the legislation. And in current legislation, public health gets some mention, but not much. Most of what is addressed there is CCOs coordinate with public health for assessing a population. That's very important to know precisely what's going on, what health assets there are, what health problems there are. In our area, there's significant differences across our 3 counties and region to region within each of those 3 counties. And so that's work that all 3 public health departments are doing currently, and sharing those findings. Benton County's health assessment will be released to the public this week. We've been working with our assessment team and with a group of stakeholders to finalize that, and we're currently working on a health improvement plan, which is the next step that all 3 counties will take, that will look at the gaps and what steps need to be taken to prioritize those and to help fill those. One of the other areas that is addressed in current legislation is the direct services that public health provides. There aren't very many of those. Most of what public health does is in the community, but we do some clinical services, including family planning, nurse home visiting, infectious disease prevention and control, and CCOs have a requirement to coordinate with public health for those services. But I'd kind of like to springboard from that to what the potential that public health brings to the game. Basically, public health is about the entire population, not a select group of this insurance plan, that insurance plan, Medicaid, private. We really are about lifting all boats. If you're familiar with the triple aim, public health has a bullseye on the middle aim, improving the health of the entire population. And that's really where we live and what we do. And we do that primarily through prevention. We definitely have to reduce costs for treating people who are already sick. We're overburdened. We've got a population that is increasingly burdened with chronic illnesses. According to the CDC, we're looking at a generation of children with a life expectancy that's shorter than their parents for the first time in American history. It's pretty startling. And public health is aimed at preventing that. So it's sort of the other piece of the pie. We can control a lot of our costs through the efficiencies that have been addressed here. That's a critically important piece, taking better care of people in a more efficient manner. Public health is aimed at reaching out there on a decade-long basis, a generational basis, and shutting off that tap and keep reducing the flow of those high-need, high-expense folks into the medical system in the first place. And just to illustrate that, I don't know how many of you have gone to the Oregon Health Policy Board website. They have some great fact sheets that illustrate how CCOs will work, how health exchanges will work. And on one of them is a story about an 8-year-old third grader named Malik. And it talks about Malik's asthma and how bringing Malik into a well-coordinated primary care clinic has really reduced cost a lot, reduced his need for hospitalization and expensive medication very dramatically. And that is fantastic, and that's a great story and a great illustration of the strength that this type of approach can bring to health. But from a public health point of view, I look at this and I say, Malik is 8 years old. He's already got a lifelong chronic illness. Malik isn't even quite old enough yet, I hope, to really be tempted by tobacco. He's not sexually active yet. He is just at the point where he's entering into a risk for obesity. If he starts smoking, if he gets fat, his asthma is going to go right back out of control. And it's going to cost the system a whole lot more. So he needs help, and he needs help through his school, through his community, through his neighborhood, through the type of things that public health brings, so that there are bike paths and walking paths so Malik can walk to school, so his mom can walk safely and keep her weight down. For public health, bending the cost curve really means bending the health curve and having a healthier community that ultimately costs us all less with resources that we can use elsewhere in our society.
So again, I'm Mitch Anderson. I'm the director of the health department, and one of the threads that I think is important across all these conversations is none of this is going to work if the people that need the services aren't engaged, so that the services and things happen in a way that work for people. There are many communities who are completely disengaged from healthcare. Maybe that's language barriers, maybe that's cultural barriers, all sorts of things. And unless we address those, again, we have only a small portion of the population getting healthcare or getting access to healthy choices. And so one of the things we felt really strongly about in developing our CCO was that the legislation calls for each CCO to create a community advisory council. And we spent quite a bit of time. We were actually a little late from our dates of needing to get things in about the advisory council, and that was purposeful because we didn't want to just appoint a bunch of people and have them start meeting. We wanted to really deliberately think through how are we going to get the best representation across our 3 diverse counties. So we spent a lot of time with design, and what we created was designed for a regional council that has 19 members, an equal number of representatives from each of the counties. And then there would be a local committee in each county, and that local committee would be kind of a home base for those regional members, a place where they could get support from the local community, but also so it put fingers deeper into the community. And on the local group, we could have a much broader representation, and that those people could get information and ideas and things there that they could then take to the regional committee to represent their group. What it also allows is for a council like this to be effective, it can't just be a token group that meets periodically and never knows enough about the system to really make informed choices and recommendations. And so the local councils are kind of a training ground where people can get involved, they can learn things. It's a place where people can then move up as seats turn over on a regional council, and what we have is a ready-made supply of folks who are really well-versed in what's going on in the healthcare system and how they can best represent their community. So we built that structure. Over the month of September, we put out recruitments to all OHP members and kind of through all our networks, and had like almost 70 applicants. For that group, we did an orientation for all of those applicants to kind of get to know them better, and then from those applicants made a selection for each county for a main group. And then what we promised was that for all of those who weren't selected on the regional group, they would be the beginning seed groups for the local councils, so that everybody who really expressed interest in being involved had a place to be involved. So that process is done now. And actually, the regional council will have its first meeting this Friday. It'll be more of a orientation meeting for that group. To help them along, we drafted a draft charter for them to look at, which we had decided that the council needed to really look at a charter about how long terms on the council should be, how they work and how they operate. So we drafted something for them to work off of at their meeting this Friday. The other piece that's underway right now is we felt really strongly that for this council to be effective, it needed to be staffed. That this really couldn't just be a volunteer group that got together once a quarter or something like that, and that you could expect that much would happen if it didn't have some staffing to really work in between the meetings and keep the movement going, to provide data, get things so that the council could really act on those. So we've partnered again between IHN and the 3 counties, and we're sharing the cost of a full-time coordinator for the council. It'll initially be a contracted position, and hopefully within a week or so, the proposal request will go out, and will involve the council in looking at applicants and selecting somebody to do that. And that person will then staff the council, the regional council, but will also staff the local councils. And that coordinator will sit on our regional planning committee so that they're very involved in what goes on. And then the chair of the advisory council will get appointed to the board of the CCO. So they'll be really networked in and connected. And our hope is that way the group can really begin to develop, can begin to really look at data. It's kind of a thread that ties what Charlie's talking about in public health to the service delivery system, because the council is really supposed to look at a community health assessment. They're supposed to adopt that assessment and a community health improvement plan and recommend that to the CCO. And so they'll be working with public health as we create those plans for our local communities. But then the council is expected to, in essence, evaluate. They're supposed to write an evaluation of how the CCO is doing annually in meeting the issues that are in that health improvement plan. So there'll be some big processes for that group to get involved in terms of really assessing what's going on, as well as we're hoping be a resource for the CCO as we develop. I think as we're looking at how we're going to roll different strategies out, though we look to the council to be a sounding board for that. The council has to be a majority of folks who are on the Oregon Health Plan, so we're really looking to say, well, we're thinking about doing this, does that work for you? Hear what the community has to say about the different ideas we're proposing and how they roll out, and that'll be part of our evaluation of whether the strategies we're moving forward with make any sense. So, anyway, I will stop there and going to do questions.